Everybody. Welcome to our event this evening. I'm just going to go through a couple of kind of housekeeping bits and then we will get started, and that will just give a little bit of time for anyone else joining as well. So I would encourage you to turn your cameras on if you would like. It's always lovely to see faces and see who's watching, and it just makes it a little bit more personal and relaxed. So please do feel free to turn on your cameras. Again, when we do questions, we will be doing this in the chat bar, but if there is a question and we've not seen it, then again, please feel free just to put your hand up or unmute, and you can speak out as well. So yes, lovely to have you all here this evening. I am going to hand over to Katerina, who is our First Five representative in the southeast of Scotland. She has been organising this series of events, so I will let her give a little bit of background into where the kind of series came from, and I hope you all enjoy your evening. Over to you, Katerina.
Thanks very much, Kirsty. Kirsty is our events coordinator, and without her we couldn't do this evening, so thank you very much, Kirsty. And welcome everybody. It's lovely to see you all. As Kirsty said, my name's Katerina Tober and I'm one of the First Five co-leads in the South East Scotland faculty. Delighted you could all make it this evening to our third in our series of renewing inspiration in general practice. Our series basically came about as a result of conversations I was having with Anna Buckland, our co-lead in South East, just about how tough the past few months at that point, and now 18 months, have been for general practice, and how maybe we thought we could invite some senior GPs, people with more experience than us as First Fives with varying interests, to maybe come and speak to us initially as First Five as a group, to talk to us about the challenges they'd faced, things that had inspired them. And we wanted people from a variety of backgrounds, so GPs with interests in education, academia, leadership, just to come and share with us, really. So to date, we've had sessions with John Gillis, Siggy Joseph, Peter Churn, and Carrie Lunan, and they've been fantastic. And I'm sure tonight will be no exception. We're delighted to welcome Dr Gregor Smith, who's our Chief Medical Officer for Scotland, to come and share with us this evening. He's very kindly given up his time to be with us, and he's very kindly agreed to a format for the first half of the evening, loosely based around desert island discs, to maybe share more personal insights with you as to some of his challenges and a bit about his career. And then the second half will be going into his first CMO report that was published earlier this year, with obviously its relevance to general practice. So I'm also delighted to have Dr. Chris Williams and Dr. David Shackles here this evening, who are going to chair the event, and of course they're RCGP Scotland co-chairs. So thank you so much for coming as well. So I'm going to hand over to them now to tell you a little bit more about the event. Thank you.
Yeah, thanks, Katerina. Yeah, simple and straightforward. And as I should say, David and I had an audience with Gregor earlier on today, where we sort of very, very much spoke about work-related things, and I guess we're coming at a chat from a very different angle just now. So yeah, we're going to follow the Desert Island Discs format, and I think that will give us a chance to hear some really interesting sounds, and to connect them, to pull things together. But I guess, Gregor, could I start by asking you to give the audience a brief outline of your background?
Thanks, Chris. Well, good evening, everyone. A brief. So I'm a Lanarkshire lad, born and bred in Lanarkshire, and spent my childhood there, spent my education there, went to university based at home from Lanarkshire, and ended up being a GP in Lanarkshire as well. So it was a pretty typical Lanarkshire story. I was a GP for 15 years in Lark Hall, and wonderful stories and wonderful experience from that spell there. Went on from there to spend some time as the primary care medical director in Lanarkshire, and gradually transitioned from there into policy jobs in Scottish Government. Became DCMO in 2015 and CMO just at the beginning of the pandemic in 2020. And it's been the quickest 18, 19 months of my life, let me tell you.
Yeah, wow. I wonder then if it's a good opportunity to go to our first track. And I wonder if you could introduce us to it and then speak about its significance for you.
Do you know, it was a wonderful opportunity for me to actually choose some music to play at something like this. Now, anyone who follows me on Twitter will know that my choice in music is perhaps not everyone's taste. But the first track that I've chosen today, it just seemed to sum up the last 19 months. And but also is one of those tracks from my childhood. I remember listening to this for the first time when I was about the age 10. And just been absolutely blown away by the guitarist who plays in this band. And at that point in time, my guitar hero was a man called Richie Blackmore, who played with Deep Purple and Rainbow. But this guy came along and he just sounded so differently that I've been a huge fan of him and trying to emulate some of his stuff ever since that time. So the song is Crazy Train by Ozzy Osbourne, and on guitar is my guitar hero, Randy Rhoads.
I think that gives us a lovely flavour, and I think there'd be lots of people in the audience who might want to track that down later on to get the fuller flavour. But can I ask you a bit about your childhood, Gregor? Can I ask you about early memories and childhood interests?
So as I say, I was born in Lanarkshire. Like many people in Lanarkshire, I took my first breaths in Bellshill maternity. I lived in Hamilton for much of my early life. It was a very ordinary life, I have to say. It wasn't perhaps a very stable life, particularly as I reached the kind of upper ages of primary school and early secondary. My childhood was difficult, Chris. I think that's one of the things I would want to come across here. I guess my family had experience of some of the difficulties that many families have across Scotland. My dad was an alcoholic, and at times my dad could be a violent alcoholic. And we, as a family, suffered the consequences of that. We found money hard to come by, like many other families. School was often disrupted because of things that were going on at home. And at times it got really quite difficult. One of the salvations that I had at that time was actually that love of education, and just the most wonderful group of friends that I had run about me as well, all of whom were into the same kind of music. And we did the kind of things that young teenagers did. We kind of got together, we listened to music, we played football, we walked the streets, we met girls, we did all those things, and just that sense of camaraderie that we had together. But through all that time, I had this focus that actually education was a way out of the life that I experienced at that point in time. I have to say that at this point in time, I owe just the most enormous debt of gratitude to my mum, who's sadly no longer with us, and also to my grandfather, who was a huge presence in my life at that point, very supportive presence. He was a man who was very reflective in his personality, who thought education was something which was really to be valued. He had wonderful socialist principles and values that drove a lot of his beliefs. And he acted really as an early inspiration in my life. But key, his best friend was the village GP, a man by the name of Ken Chisholm, Dr. Ken Chisholm in Bothwell. And I think Ken was one of those inspirational figures that I certainly came across in my life, who, as soon as I ever got into a conversation with Ken, I didn't want to be anything else other than a GP, and a GP in the way that he was.
Gregor, I'm wondering that as well as me asking questions of you, there's also the facility for people to ask questions by using the chat bar David will sort of keep an eye on the chat bar as it fills up. But I certainly hope if people have got questions for you that we can sort of pick up, you know, some of those at the end. But I wonder, moving on to your second choice, I wonder if that gives us a sense of movement. Can you maybe give the name of the second choice?
So my second choice is my absolute favourite song in the world. I don't know how many times I've heard this song live, but it never fails to kind of really just grab me. And it's probably because it's so evocative of a period in my life. The song is "Hallowed Be Thy Name" by my favourite band, Iron Maiden.
Thank you for that.
Are you starting to see the theme here? There's a lot of guitar-based songs that we're kind of listening to just now.
I can see a pattern forming, but there's still several choices to go. So we'll see what progression there is. But you talked about education, and in terms of university, in terms of study, can you tell us a bit about that and your experience of that?
Yeah, so I went to Glasgow University. I'm really proud of the fact that I went to Glasgow University. I met some wonderful friends there that I'm still in contact with. But I think I probably came across from that kind of first conversation. I was the first person in my family that had ever gone to university. And so it was a bit of a strange, and can I say it was a daunting experience making that transition from school to university. And again, I think it's probably only because of the support I had from friends around about me, and also from people like my grandfather, like Ken Chisholm, who were able to act as that little bit of source of mentorship and just support that I found the transition something which was a little bit easier to cope with. But actually, Chris, I mean, one of the features that I think is really important is, as someone from a kind of comprehensive school background who's no experience at university, making that transition wasn't easy. We're going to change the face of medicine so that we allow access to clinical careers, whether that be through medicine or any of the other kind of clinical disciplines, a little bit easier, so that people from lots of different backgrounds are supported to pursue careers like that. I think that widening attainment agenda, which has developed in Scotland, particularly over recent years, is something which is particularly important, I've got to say, for the specialty of general practice. Now, I went into university not wanting to be a doctor, but wanting to be a GP. It was very, very specific, and I remember that right from an early stage. And all my studies all the way through university, which I really enjoyed, were with that one goal in mind: what would make me a GP in the future, and how would I construct a career that would allow me to practice in a particular way? Because it was that longitudinal care, that relationship-based care, which was really attractive to me.
And would you be able to sort of identify any particular influences at that stage?
Influence, yeah. I mean, as I say, Ken Chisholm was a huge influence on that part of my life, just in terms of, in fact, when I graduated, he gave me a thermoscope, and I used that for years just out of sentimental reasons. He'd retired by that point in time, but there was something about hanging on to that tool, which was really important. So Ken was just that wonderful source of quiet leadership, quiet mentorship in the background, just providing that support. But I came across lots of figures during the course of my studies that were like that as well. Some of my friends, a colleague of mine, Sean Tomlinson, who's a GP in Motherwell, was quite inspirational in terms of the way that he approached his studies. But people like John Dagg, who was a clinician at the Western Infirmary in Glasgow, Jim McKillop, who was a physician in Glasgow Royal. These were people that you saw, and I have to say that for me, you wanted to emulate in terms of their wonderfully compassionate, empathic approach to patient care.
Yeah. I wonder if it's a good opportunity to bring in a third track if we're moving on from quiet inspiration.
So quiet inspiration, I mean, another one of the guys that has been there in the background. I mean, I sometimes look outside medicine for inspiration and for things that really keep you going in life. And this guy, wow, what a life he has had. He's a man called Dave Grohl. He's the lead singer, sometimes guitarist, sometimes drummer of a band called the Foo Fighters, and was also in a little pop band by the name of Nirvana before that. But Dave Grohl is just one of those guys who he's kind of earned this epithet as the nicest man in rock. And you can, if you ever hear an interview with him, you understand why. He's remained, I think, very humble, very confident in what he's able to do, but very down to earth and grounded. And the song that I've chosen from the Foo Fighters, again, is evocative of a wonderful period of my life, and it's called Everlong. I kind of want to get my guitar out now, Chris.
Well, I think you're finding more favour with the audience. I can see more heads nodding as we're going along. So I think you're hitting the right notes. And you'd mentioned about some of the I guess the barriers and challenges and difficulties early on in your life. In terms of your professional career path, I wonder if I could ask about the challenges that you might have faced in that context.
I remember as a junior house officer in Glasgow Royal, I was fortunate to get a job in the university department there, and actually worked with Jim McKillop that I spoke about a couple of minutes ago. And I had the most wonderful time doing medicine there. And I can remember an early conversation with the educational supervisor, who wasn't Jim McKillop, but was another consultant in the unit. And her hauling me into her office one day. It was the only time I ever got shouted down in medicine. And she asked me why I hadn't applied for the Glasgow Royal Medical rotation. And I told her it was because I wanted to be a GP. And she berated me and told me that I lacked ambition for wanting to be a GP. And I just felt that was an utter misunderstanding of actually what drives people into a career in general practice. As I said before, I wanted that relationship-based care, that longitudinal care, to be part of a practice team. And I was very fortunate that after doing my training with the most wonderful trainers in Hamilton, David Dobie, Murray Herbert, Alistair Graham, I found a practice in Larkhall that really suited me. It was a very forward-thinking practice. We were probably the first practice in Scotland to go paperless back in the late 90s. And they had a really good setup. They had quite an independent IT system that was really kind of well constructed. At that point, they were fund holding practice as well. And I guess that transition from what's a kind of protected environment within the hospitals as a trainee into a GP principal was something which for me was made much, much easier by this help and the support of some of the partners in that practice. Hamish Smart was the senior partner at that point in time. Hamish sadly died a few years ago. But again, he just had this wonderful outlook in life. He was a bit of an extrovert. He loved the conversation and he had a brilliant sense of humour. But he made sure that people were supported in that practice. And I think that's a really important element of this transition from what were the kind of training grades into being an independent principal practitioner. I think that there was a really strong lesson for me in that. And I was very fortunate in that it was a very supportive practice that I was in. And gradually I wanted to branch out and start to seek interests outside the practice. And I'm forever grateful to my partners in the practice for allowing me the opportunity to do that, because there's no doubt about it. As I did that, there was a slightly greater onus on them to provide cover for me. Their actions allowed me to kind of take up those interests at that point in time. That's not to say that any practice, as people on this call will know, is not without its challenges. But the really important aspect of those was just those open and very honest conversations that you need to have in a very respectful environment with your partners, in order that you, I guess, work at the partnership in the same way that you would work at any long-term relationship.
you clearly had a drive, not just for medicine, but for general practice. But if you, I sort of suppose might ask you to imagine if you hadn't studied medicine, have you any thoughts on, I guess, what life might be like now, or if that thing that you've had that single focus around wasn't there?
Well, there's the fantasy version and there's the reality, isn't there? And I guess the fantasy version is that perhaps I would be given this interview as the kind of lead guitarist of, I don't know, the Foo Fighters or Iron Maiden or something like that. But wouldn't that have been a wonderful way to spend your life touring the world and getting to kind of play your art as much as you could? I guess I would probably have drifted to another direction. I'm quite an empathic individual, I think, and I think it would probably have been in a caring profession of some sort that I would have drifted towards. I'm not sure what exactly that would have been, but I think and I hope that it would have been somewhere within health that I would have found my home to kind of to provide a care from some perspective if I hadn't ended up where I am just now.
Yeah, I think finding a home is such an important thing in life.
Chris, there's a sense of belonging that's really important as part of a career that people develop, and I think medical careers have changed over the years, and that sometimes people found themselves in a place and they never moved again. I think medical careers have changed from that. I think that's a good thing. I do think that's a good thing, but I do think that there's still something to be valued about finding the place where you fit. And that might be in a particular practice with a particular way of doing things. It might be in a particular community because the type of care that you can provide there. But I do think that there's something that's really important about just finding where you belong that fits with your values, so that as you continue to practice and work with your colleagues, there's not that sense of dissonance that starts to creep in terms of the way that you do things. It's so important that we trust those teams around about us in a way that allows us to be free in the way that we practice, and that we find people with similar values to ourselves as we're doing that as well.
I suppose in the spirit of trust and similar values, I might ask you to introduce your last musical choice. So
my last choice today is a little bit of a departure from the guitar music we've heard so far, and this is a band that I was introduced to by one of my best friends, Brian. And the reason I've chosen this track is because it represents possibly the last gig I was at before the COVID pandemic struck. And I remember being at a venue in Glasgow called SWG3 on a wonderful late summer evening, with the sun absolutely splitting the sky, as this band came on stage, returned to Glasgow after many years away. They're from New York originally, but Glasgow is one of their spiritual homes. It's a band called LCD Sound System, and the track is one of their, in my opinion, one of their best tracks, which is called All My Friends. And believe me, Chris, after a couple of refreshments and in the late sun, when that song comes on, you can't help but dance to it. Yeah, and I suppose there's quite a broad spectrum of musical choices that you've included. As you mentioned, many people will know about the rock side of it, and I wonder if there's any significance behind those attachments. You'd mentioned a little earlier about sort of having friends around and sort of and growing up with rock. Is it just for listening to? Does it go beyond that? So I think I would use the word evocative on a couple of occasions. I think music's a little bit like smell, in that as soon as you hear a song or a track, it takes you back to a time. It generates an emotion in you, and I think that's a wonderful aspect for me, certainly, of listening to music. Music becomes a really important part of my life, both in terms of being able to just enjoy and appreciate brilliant songs, but also to try and join in sometimes when I get the opportunity as well, and try to play them. It's always been a big part of my life, and I think it's that sense of being able to enjoy with others some sort of shared experience. So going to gigs with friends, having a party where you're listening to music, getting the guitars out with friends, all that kind of thing becomes really important in terms of how we express our individuality and personality.
I think we'll pick up on that a bit later on as well. But as at the moment, I might like to ask about a book in the Desert Island discs specifies that we ask you about what book you might take, and give us a reason why.
Yeah, I mean, this is a really good question, and I struggled at first to pin it down to just one book, but eventually I did. So first of all, the book is called Thud, and it's not so much the book that I chose, but it's a combination of the author, Terry Pratchett, and the character who's the central character in Thud. It's a man by the name of Sam Vimes, and Sam is a reluctant hero in the book. He comes from a very humble background and makes it to the upper echelons of this society, first through the kind of police force of that time, and then into the kind of royalty of that time as well. But the thing that attracts me about this book is the wonderful humour that Terry Pratchett weaves through the story. I mean, the book is, in my view, hilarious, but there's a central message which is, again, goes back to a conversation about values, what's important to people, and how people respond when those values are challenged. And Sam is an incredibly principled person of huge integrity, and when that integrity is challenged, he responds in a particular way. So I just think he's a wonderful character. He has some traits that I can identify with. And if you ever get a chance to read a Terry Pratchett book and you're feeling just a little bit down, it always brings a smile to my face.
Thank you. And as you say, an author that I think has also sort of made an impact beyond just his writing, in terms of his willingness to share, with a much wider audience, the illness that he went through, and that he could sort of see was, was going to, he was going to have to endure till his last.
And that openness comes out in Terry Pratchett's writing, I think, and that ability to be able to speak about the human condition. And there's something, it's a real skill that I think is to be able to do that in a way which has both elements of pathos and absolutely, I mean, fall off your seat humour, side by side. And as I say, he was an incredibly talented author who was actually wonderful to listen to in a spoken interview as well.
I guess I'll go back to the desert island and to ask you, I suppose, in terms of a final item, a choice of luxury. What would you take with you, and why?
This was probably the easiest choice, I think. The luxury that I've chosen is one of my guitars. It's a particular guitar by a luthier Jackson. It's called the RR Pro, the Randy Rhoads Pro. It was the guitar which he christened Concord, and was a prototype which actually launched the Jackson Company back in about 1980. And I managed to get myself a kind of copy of it. And it's important to me, partly because it's just a guitar I love playing, but it's also got sentimental importance as well. When my mum died, as I say, prematurely a few years ago, she left me just a little bit of money. And one of the things I did with that was I bought that guitar. She bought me my first guitar when I was about 11 years old, and I had that for years, and it just seemed fitting and right that I bought another guitar at that point in time that I could keep with me as a kind of memory that was special for her as well.
And it might help the audience. Would they recognize the shape?
You know, I should have if I thought ahead, I should really have got it for to bring here. Should I could maybe even have played something. It's a beautiful white flying V guitar, and it's got some lovely kind of very gold hardware on it as well. So it's the guitar that Randy Rhoads used live very often, and maybe we can post a wee picture later, just of Randy Rhoads playing his version of the guitar, and I could maybe even get a picture with mine here.
I think pictures are part of memories, but I think you've taken us through all sorts there, and lots for us to think about. I wonder if we've had any questions into the chat.
No questions in the chat at the moment, but hopefully we'll get some posted. Gregor, thanks very much. I think Roy Plumley got the format right for Desert Island Disc, didn't he? It's a really good way for introducing yourself and leading you through a life. Just we'll wait and see if anybody does post a question. You've given some nice personal reflections for that. I'd just like to ask you, thinking back to February, March 2020, as an individual and as DCMO, what were you thinking?
I remember vividly a conversation with one of my senior medical officers at that point in time, in the week between Christmas and New Year, when he came into my office, and he was updating me on something else, and almost as a kind of afterthought, he said to me, "By the way, we're keeping a little eye on some strange respiratory pneumonia cases that are showing up in a place called Wuhan in China. Might not be anything, but the reports that we're seeing from it are certainly raising some eyebrows." And as I said, that was the week between Christmas and New Year. By that point in time, you were starting to see some news trickling through from Wuhan that there was something unusual that was going on there. But of course, information was really limited at that point in time. As you started to go through January and into February, it was becoming very evident that there was a significant issue that was in play. And I think one of the characteristics, particularly of that early stage, which will stay with me most, is the inability to get any firm intelligence as to what was going on at that stage. It was incredibly difficult to try to separate the rumour and speculation from the fact, and there's probably lessons that can be learned on a global scale in addition to that, as we look back and we reflect on the response to the pandemic. But there was certainly a gathering storm, and I think all of us appreciated that things were going to get difficult, but I don't think any of us appreciated it was ever going to reach the kind of depths of difficulty that it subsequently did. And when you think that it was only a matter of weeks later that the whole of Europe streets were emptied, and people were finding themselves locked down in their homes, I guess that was scenes that I never really expected to see in my career, if I'm being honest. And it was the strangest of situations to find myself at the centre of, I have to say. And then to transition from DCMO into CMO, just a week or so after lockdown commenced, was just, one of the most, I guess, challenging, difficult situations that I've ever had to face in my career. And believe me, there's been some very dark moments since that point in time as well.
That moves on, it's a good link into one of the questions there from Daniel Simpson. I mean, he's asking us, what made you move then? You really wanted to be a GP, that was your aim. So what was it? What was the trigger? What made you move from that bit of direct patient care, being the GP in the environment you'd valued, you'd wanted to do? What made you move on into these current positions of more public health facing and into your work, talking about clusters as DCMO and then as CMO work? What was the trigger for that?
I got frustrated. I got really frustrated at things that I saw in the system that didn't seem to work properly. I got frustrated at problems that I saw in the system that just didn't seem to be going away or improving. And in those kind of situations, you've got a choice where you sit in the periphery and you throw bricks and you moan, or you try to get involved and to change things. And the first steps that I took was actually just in the quality dimension. It was just as a kind of clinical governance lead back in the early 2000s. I was invited by some of the local older, more senior GPs to kind of become part of the clinical governance committee at our kind of locality level, and I really enjoyed that. And from there, I developed I was always interested in respiratory care, and I became a kind of co-chair of a respiratory managed clinical network at that point in time. Really enjoyed the opportunity to make change, instead of just on an individual basis within the practice, at a slightly greater population basis, and to make improvements that you could actually see had an impact beyond even your own practice doorstep as well. And from there, it's one of those, once you're in that system, you gradually find that more and more doors begin to open, and you have the ability to be able to influence things in the way that you hope care will develop a little bit more as well. And eventually, 5 or 6 years ago, 2014 or 15, I think it was, made the kind of rather difficult decision at that point in time to kind of throw my lot on wholly in terms of trying to make that difference, particularly at a policy level, and try to develop a vision for the way that we provided care. I was very fortunate at that point in time that working with Kath Calderwood, we both had very similar vision for how things could be, and that's where realistic medicine as the concept it began to arise back in the very early stages of 2015, that would be. And publishing that first report where we tried to describe the potential for a different approach to care, something that actually tackled some of those real thorny issues that we saw within the system, to try to kind of almost update what we saw as medical professionalism. Was just the most wonderful opportunity, and too good a chance to miss. And I miss the day-to-day individual patient care. I still bump into patients every now and again, and it's lovely just to get updates on them and their family, and to chew the fat with them for a wee while. But having that ability to be able to influence care at that greater level is something which I've felt privileged to be able to do.
That's great. There's a couple of comments in the chat about a comment you made about your first-hand experience of the negative view of primary care, the lacking ambition, some of the denigration for that. And people are asking for your assessment, how you feel that is now, how we might tackle it. But with the element that one thing you said, you've found your tribe, which is great. That's a positive element of it. But there can be negatives in that tribalism within the health service.
Yeah. I mean, I think tribalism is a real problem, and I think that we've all seen it. We've probably all experienced it. Everyone who's participating in this call. I think it's something that we need to move away from. I think that over recent years, there's certainly been a much stronger voice from within general practice, which I welcome. I think both the college and also the BMA have been really important in trying to make sure that specialties which perhaps haven't had their place recognised in the past, whether that be general practice, whether that be specialty psychiatry, there's others I could mention as well, such as public health, that actually that those are given the respect and the prominence that they're due. I don't think, and this is from my experience, I don't think there's a harder job in medicine than full-time general practice. I've just got to be honest and say that, because it's not until you've worked within general practice that you understand the degree of risk that you absorb personally on a day-to-day basis, as you see so many patients in such a short timescale. And we rely very much on both our clinical acumen, but also our our skill in communication and our sense of being able to connect with others, to be able to do the job both safely and effectively. And I think that that's a skill which is almost like no other part of the profession. I think that there's still work to do to make sure that all parts of the profession are equal, are recognised equally. But I do think that it has moved, and I think a strong college in the background playing its role within a strengthened Scottish Academy is one aspect, which is really important in ensuring that all the venerable institutions and all the professionals who are working in the system have that sense of mutual respect for the role that each other has to play. And what I'm delighted to see acknowledged much more readily now is this term expert medical generalist. We were speaking about that just this afternoon. And it was something which we started when we did the contract negotiations, that first Scottish contract back in about 2012, when I first became involved in the Scottish Government. Alan McDevitt was the chair of SGPC at that point in time. John Nugent was another SMO that I was working alongside. And we started to speak about this concept of expert medical generalism. And I really do think the concept of general practice as being consultants in family medicine or consultants in community medicine is something which is really important, and something that we need to make sure is that it's properly understood by everyone involved in the system.
That's great. That's really helpful, Gregor. Just before we move on to your report, a final question to sum that up. And given what you've just said, a question here from Ismail is a really, pertinent question. Given all that you've said and your experience, what advice would you give to a doctor just early into the CCT? Somebody starting their journey now. What advice would you give them?
Enjoy it. Is the thing, and I know that's not meant to sound flippant. Enjoy, gather as much learning during your training as you can. Don't rush into a practice until you think that you're ready for that independent principle, to practice as an independent principle. And as you're deciding which practice to join, my own advice would be to make sure to test it out and to make sure that it's consistent with the way that you want to practice and consistent with the values that you hold dear to you as well. I know people who have joined practices where perhaps the values within that practice weren't quite a fit for the way that they wanted to work, and that's led to problems for them. So do your homework and get to know the people that you're joining. You're going to be in a long-term relationship with them. You wouldn't marry someone after just one date. You would want to get them to know them just a little bit longer. And I think the same advice probably holds true for becoming a partner in the practice as well.
Good advice, I think there. Good advice. Okay, Gregor, we're going to hand over to you to present your report. We hope there's going to be some time for questions and answers at the end of that. So please, if you would all keep your questions coming, we'll see what we can get fitted in at the end of Gregor's presentation. Thank you.
So thanks, David, and Chris, for what I hope was at least a semi-interesting session, just to kind of maybe gives you a sense of where I've come from in forming this report. This was my first report as Chief Medical Officer, Recover, Restore, Renew. We had to miss out the report during the pandemic, unfortunately, just because there was no way that we could ever do the work that was needed to go into the report. So this was an opportunity for us to maybe reflect on the shared experience over the course of the pandemic. I think what we'll do, Kirsty, if we can, is if we can just move on to the next slide. This gives you a sense of what we wanted to try to achieve when we wrote this report. And I have to emphasise, just like the reports before it, since the first realistic medicine report was written 5 years ago. This is very much a team effort, and there are a number of contributions from different people within this report, which was wonderfully shepherded by two of my Scottish Clinical Leadership Fellows, Savita and Julie, who really did all the editorial work on it, and I have to congratulate them for the product that they produced. It was exactly as I hoped that the report would be, and it focused on the areas that I thought that were very important. What we wanted to do was, as I say, allow that opportunity just to reflect on the experience both of the profession, but also how it's impacted in the Scottish population over the time of the COVID-19 pandemic, but to try to pick out some of the wonderful examples of the care that has been provided during that time, the good practice that developed by necessity over the course of the pandemic, but also some of the good practice that was very consistent with the principles that we described over the previous reports in relation to realistic medicine. We thought that this was a really good opportunity to actually start to build on the momentum for change that was developing, particularly to expose some of the issues that we knew had been long-held problems around about health inequalities. And we hoped to be at least thought-provoking and to inspire action on the part of some people to kind of join us in what we thought was an opportunity to kind of start afresh as we kind of recovered and remobilised the workforce. So the next slide, please, Kirsty. It was born of kind of 5 sections. The first of those was the health of the nation. Every CMO report has to have a little bit of a state of the nation aspect of it, where we look at some of the important data in relation to the health of the nation. But one of the really important aspects of this report was actually to highlight the fact that even before the COVID-19 pandemic struck, what we were starting to see from about 2012 was that life expectancy trends in Scotland were beginning to stall. And in fact, life expectancy in the kind of 40% of the population who suffer, who come from our most deprived communities, it was actually starting to reverse in some instances as well. That was, to me, a really stark warning, something that we had to speak about and to try to work out what we could do to try to reverse that trend. We also acknowledged the terrible impact that COVID has had on the population and the excess deaths that we've experienced as a consequence of that. Not only the mortality that's come about as a consequence of COVID, but actually the deep social impact that it's had as well. One of the things we've tried to do as we've managed the pandemic in the Scottish Government is we've used what we call the 4 harms to judge how to respond. So those 4 harms, if we go through them sequentially, the first and the primary harm that we've been focused upon over the course of the response has been the direct harm which has been caused by COVID-19 itself. The second harm that we refer to is the harm caused by other illness and disease, which is impacted because of the volume of care which is necessary to address the pandemic. The third harm is the harm that society experiences as a consequence of some of the measures that we've had to put in place, and that also has health harms as well. And the fourth harm is the economic harm. Now, each one of these harms ultimately has some sort of impact on public health, whether it's COVID itself or whether it's the economic harm that arises from the response to COVID. And it's a really important principle that all through this, it's about balancing the impacts of each of these harms. The impact in society has been quite remarkable, both in terms of educational disruption and therefore educational attainment, one of the greatest predictors actually of long-term health, and even down to the kind of loneliness and mental health distress that some people have experienced as a consequence of that as well. And we go into some discussion around about that. But the economic impacts, as I say, you might not expect that the economic impacts is something that we would mention in a CMO report, but it's really important to acknowledge that even with those economic impacts comes longer term harms that are going to be difficult to quantify at this moment in time. But over the course of many years, I suspect will reveal themselves to be some of the hidden harm that's yet to manifest itself as a result of the pandemic as well. And a large part of this Health of the Nation section was really run about the inequalities which certain sections of society have experienced as a result of the pandemic as well. All-cause death rates were up by 1.9 times in the kind of the most deprived communities, and the COVID-19 death rates up over 2 times, 2.3 times as well. I think that we properly understand that, but like any pandemic that has arrived before it, what the COVID-19 pandemic has done is it's widened those health inequalities that already exist in society, and has disproportionately impacted on those who already are more likely to suffer most as well. The second section that we drew upon is the delivering personalised care. Many people will be kind of familiar with this from aspects of the realistic medicine reports in the past. This was trying to demonstrate how the principles of realistic medicine had come to the fore during the course of the pandemic response. One of the gratifying things that we saw was that when people were coming to us with innovative solutions for things that they could see could be done differently during the pandemic, the realistic medicine principles, particularly about delivering personalised care, were right at the core of those responses. And we try to do that as well with responses such as the approach to shielding in Scottish Government, where initially, although we had to very quickly develop an approach to shielding to try to protect those who are most vulnerable, what we gradually evolved that too, as we understood the kind of terrible burden that many of these people faced by the process of shielding, is to be for them to be able to risk assess their own risks and how they approach life by provision of adequate information to them. We saw the GMC guidance on informed consent, decision making and consent being produced during the course of the pandemic. That again was another really important aspect of trying to develop our approach to shared decision making and understand what we mean by that personalised approach to care. And then 2 really important aspects of the pandemic response: anticipatory care planning, which was a huge part of daily practice in general practice, and was supported, I have to say, really significantly by efforts from the college in terms of developing the guidance and ensuring that when people were taking that approach to anticipatory care planning, it was done appropriately. Treatment escalation plans were something which were developed as well, and again became a really important tool to try to convey a sense of what people's aims and goals were from their treatment when they went into hospital, so that futile approaches to care were not deployed and unintended harms caused as a consequence of that as well. I think we could probably move on to the next slide, because I'm really keen that we get into any kind of questions about this rather than dwell on the some of this substance. And this was an opportunity to really kickstart our approach to try to reduce health inequalities. It's something which, an approach we've tried to kind of improve in Scotland for many, many years, but it's been really difficult. And my view of this is that we can't do this in health and social care alone. This needs to be an all-society approach to reducing health inequalities if we're going to make any kind of difference and impact on it. Over the course of the pandemic, one of the features within Scottish Government, which I think has been, for me, very helpful, is that chief advisors from different parts of government have come very much closer together, so that I'm as likely to have a conversation with the chief economic advisor, Gary Gillespie, as I am with the chief pharmaceutical officer. And I think that that's really important when it comes to how we approach this aim to reduce health inequalities. We have got a terrible record in Scotland. We have to hold our hands up to that. But I do think that we can improve upon it by working much more closely, not just within government, but across government, local government, the different community groups, which are the Evidence Society, and using our unique leadership position within health as to provide that sense of leadership to the approach, because ultimately we see the impacts that health inequalities have on people that we care for, and I'm quite sure that each one of us would want to be able to play our part in that. We've got a wonderful opportunity with institutions that have become referred to as anchor institutions within our communities, and I think health services is a really important aspect of that. We are trusted sources of advice to our communities, and working out how best we can play our part in reducing health inequalities, working with those other groups, whether they be from other parts of public or private sector, is going to be really important. But I'm absolutely convinced that it needs to be, as I say, a full cross-government approach that takes a social policy, economic policy, as well as health policy, and train together. And then the next chapter was something which was very personal to me. I think if you're anything like me, you probably found the last 20 months the most challenging spell of your career, and I recognise very much the impact that this has had on colleagues up and down the country. Some of the statistics I've seen in relation to this have been, frankly, just heartbreaking, and some of the stories that I've heard given firsthand from people who've just experienced this sense of overwhelming helplessness at times in terms of the response is something that we just can't ignore. And so there's a really important aspect of this recovery period where we make sure that we provide the means by which our workforce, our colleagues, have the ability to be able to recover themselves, whether that be through the various support mechanisms that have been put in place, whether that by ensuring that workforce planning for now and the future is fully cognizant of the gaps that existed even before the pandemic struck, and builds and strengthens even from that point in time, but provides leadership as well, which is understanding of exactly what it's like to work in the system just now, and to provide that, what I think is been described as a compassionate approach to leadership, but I think is just giving a sense of understanding, listening, humanity, and trying to address the problems that we know exist within the system just now. And a really important aspect is to recognise within that the diversity that we have within our workforce, and to make sure that we have as inclusive an approach to that as we possibly can. And this chapter begins to develop some of the work that is underway to try to do all of that. I think this is one of the biggest challenges that we face as we begin to recover from the pandemic. I know that we still feel as though we're deep in the middle of it just now, but it can't wait until the pandemic's over before we're doing that. This is needed just now, and it's something that we must continually check ourselves against to make sure that we're doing all that we can do. And then the last section is about a green and sustainable healthcare. As we speak, people are arriving in Glasgow for COP26, possibly the biggest world conference that we've had since 2015, which was when the Paris Agreement was made. And it acts as a wonderful opportunity for us to renew and strengthen, I think, our commitment within healthcare to action on climate change as well. Climate change affects healthcare in three different ways. There's, first of all, there's the impact that the delivery of healthcare has on the climate, and this chapter deals with a lot of the initiatives which relate specifically to that, and how we can make small changes, again providing that local sense of leadership to make sure that we're doing all that we can to reduce our carbon footprint. If one of the statistics that we've used within this chapter is that if healthcare were a country, it would be the fourth largest producer of carbon emissions of any country in the world. And that's a staggering statistic. And there's small things that we can all do that begin to make a difference. green and sustainable healthcare goes just beyond that as well, although that's the impact that we have on the climate. One of the things which I think that we have to acknowledge, which is going to come very much into the agenda at COP26 when Health Day takes place on the 9th of November, is both the impact of climate change on human health and the changes that we may begin to see in countries like our own as different types and patterns of infectious disease begin to emerge as a consequence of that climate change, but also the way that we can make health systems more resilient to be able to respond to climate change as well, whether that be the kind of severe weather events which we're more likely to see, whether that be the sustained issues that are possible as a result of changes in air quality or in the kind of background temperatures that we see as well. So these are things which, again, I think are really important that as a profession, we play our part in to openly discuss and to kind of really challenge ourselves to see exactly how we can respond to that. And I'm delighted I'm going to be about to take on the role as co-chair with John Burns, Chief Operating Officer of NHS Scotland, in a new group which is going to be looking at sustainable delivery of healthcare in Scotland in the future as well. And that's something which I think is really important that as clinicians we become involved in as well. That's a really quick run through of where the report is. It's fairly superficial, I'm afraid, in terms of the way that I've gone into that, but perhaps it gives a sense of where I think the priorities for the CMO office are over the coming years. And that's where myself and my team are certainly going to be focusing our work on. I'm hoping that some of you listening tonight might feel inclined to kind of join us and to try to do something about some of these things. And I guess what I'm looking for you to try to do is to think about the small changes that you can make in each of these dimensions that can make a material difference in the way that we provide care and the quality of care that people experience in Scotland over coming years. And I am really keen that we continue this conversation and we continue to listen around about how we can make that better. David.
Gregor, thanks very much for that run through. It really is interesting and illuminating to have you explain through it. We could read it, but it's great to have you talk to it. I think that really adds value to it. I am delighted to see the focus on sustainability and climate within the report as well. You may know that is one of our RCGP Scotland priorities over the next 3 years. And along with Scottish Academy, we have a release tomorrow on climate and sustainability with healthcare as a press release going out with that. And we look forward to working with you for that very, very much in the future. Okay, so I'm hoping that people will start to put some questions into the chat now, both about that and that report and some general questions. What I'd like to kick off with is a question, which is around the realistic medicine and personalised care agenda, because we've got a difficulty here, haven't we? We want to do that. We want to work with that. We've got a workforce problem. We've got increased demands for access that's been going on even pre-pandemic. We've got difficulty with continuity within the service because of that. How do we square that circle? What sort of steps do you think we can take to make that work?
I'll just start with an easy question, David. I think it's a challenge just now, isn't it? But I think we can look to where there are really good examples of people who've been able to do that. And so one of the things that I would want to highlight, which I think has made a tremendous difference to being able to provide personalised care. Remember, personalised care is something which is about actually meeting people's preferences for the way that they receive care and for the type of care that they want that's in tune with their own goals as well. And so if I picked out NHS Near Me and video consulting as one way where we can innovate to provide a different approach to care, which I think is wholly appropriate in some circumstances, then I think that is something which helps us to define more clearly how general practice might operate in the future. And there will always be a place for face-to-face consultations. There has to be. But I think it's right that clinicians and people come together to decide how they want to receive that care and to have options within the system. And I think when NHS Near Me, for me, is certainly one of those features of the pandemic, which is something which I think we would want to hang on to in a way as well. But we need to support people to be able to do that as well. So some of that is about first developing a much better understanding of health literacy levels within the system. And for those who need a little bit of support, to receive that support, whether that's using particular questions as prompts, as we've done with NHS Near Me, or whether that be about using other materials that people can use in the consultation tools that can help to kind of promote shared decision making as well. And that equally works well, whether it's a face-to-face conversation or in a kind of video consultation as well. I also think we need to start much earlier about educating people about health choices. And Sarita, who I mentioned earlier, who's one of the clinical leadership fellows who was responsible for the last report, is doing a piece of work for me just now, continuing a piece of work for me just now, which is looking at how we begin to perhaps even influence the curriculum in schools to promote a greater sense of health literacy as well. Because I think if we can empower people, provide agency for them to be able to be part of these conversations much more readily, what it allows us to do is it allows us to take that much more personalised approach to care, to have a broader understanding of how to access the system and to know exactly who to turn to when that time is right. I think that communication there is still got a little bit to go. I think that people's degree of stress and distress at times over the last 18 months has made some of that communication difficult, and you can see that playing out very openly in certain parts of the media just now. But I'm in no doubt that what we can't do as we exit the pandemic is simply go back to a way of working that we had before the pandemic. I don't think that that is feasible, and I don't think that's desirable either, because I think that we need to be able to continually move the boundaries of how we advance clinical practice.
Great. As a follow-on from that, Robert Duncan's writing in the chat and saying, he applauds all the realistic medicine reports and themes, as I think, the vast majority of general practitioners and all health practitioners do. But he's wondering, how much do you think the public has engaged with this agenda, and how can we all do better to get further engagement with this? Because it's really about that, isn't it? It's not whether the medical profession engaged, it's about the public engagement. If the public are exhausted by health during the pandemic, what kind of steps do you think? What's it going to take? Is it something for us, or is it national advertising? What is it that's going to grab the public interest again about more health once the pandemic's over, or are they just wanting to forget about it?
We had really built up some good momentum with realistic medicine just before the pandemic had struck. We had wonderful advice from the citizens' jury that we had formed in terms of what needed to happen to make realistic medicine more likely to happen from that public perspective. That was all in the process of being implemented, and of course the pandemic came along. It's like so much, it's been delayed or slightly blown off course as a consequence of that. But there's an opportunity to revisit all of that stuff. I think the public, my sense is that the public are tired just now, fatigued by everything that has happened to them. So we've got to do this sensitively. We've got to do it for the right reasons. But we should also make no mistake that actually, in order that we have a sustainable universal healthcare for the future, we need to have those conversations. When you look at the pent-up need that there is within the system just now, making sure that we prioritise those with the greatest need is something which is going to be really, really important. And one of the ways that we can do that is to make sure that we're using the resources within the system much more effectively than we've done before. We have, as a profession, perhaps used an awful lot of approaches in the past which have been lower value in terms of their impact on improving people's health. And we need to revisit that. And we need to have those open conversations with the public around about that. Now, I'm very happy and willing to be able to kind of start that conversation, which we will do. I would be an awful lot more content if I had people like yourself, David, alongside me from the Royal Colleges, who were able to use their credibility and standing with the public as well in having those same conversations. So it doesn't seem purely that this is government doing it to the population, but actually this is about professionalism and best care, which should be at the heart of everything that we speak about. Don't underestimate the trust that there still is there for the profession of medicine. I think that's one thing which comes through very, very strongly. It would be easy to pick up certain newspapers and feel as though the whole country is turned against you at times. But my advice to the college and to people who are on the call is kind of consistent with something Chris said at the conference last week, which is about don't ever take advice from people, or don't ever be worried about the advice or the criticism you receive from people who you would never take advice from. And I think that's a really important aspect. As a college, as a profession, we should be confident about the care that we provide, because it's high quality care and it will continue to be high quality care. And I think if we have that honest dialogue with the public in a way that they can understand, then that's going to be a really important aspect of making sure that the principles we've described in realistic medicine lead to a sustainable approach to healthcare for the future.
Great. Another, moving away from that topic, so another pandemic, Michael Blackmore's asking about your view on the drug-related deaths, the epidemic within the epidemic. And this chimes very much with a bit of work that we've been doing at RCGP Scotland on drug-related deaths. We hope to be releasing soon. How can we get GPs to engage more with still suffering addicts? What can we do about our addiction epidemic?
Yeah, I think this is really important, isn't it? This is something which I certainly saw a lot of in my practice. I'm quite sure many people in this call have done the same, but it's got worse probably even since that point in time. And I think it is an epidemic. It's certainly a crisis within Scotland. When you see some of the figures in relation to drug-related deaths and the impacts that has on families and communities, then again we go back to the point. It's those. It's the widening of health inequalities in action, because it's those who come from most deprived communities that are most likely to suffer as a consequence of this as well. So there is a significant amount of action in play in relation to how we combat this, but I would hope that general practice could certainly play its part in that. Now again, general practice isn't going to provide the answers to this, but when you look at particularly the age groups where many of these drug-related deaths are happening in, it's not necessarily young people, it's older people a lot of the time. And very often there are other reasons and precipitants in the background as well. I'm struck by the inequalities that people with addictions continually suffer in terms of their physical health as well. And I think, even if we go back 10 years, there was good evidence at that point in time that those who suffered addictions, whether it be to alcohol or to drugs, were actually more likely to have greater physical health inequalities as well. I think general practice has to play its part alongside specialist services in supporting people through that, and to making sure that just as we would any other vulnerable individual on our practice list, that we're doing all that we can with these people as well. And I recognise from experience that it's not always easy, but it's about developing the approaches and the empathy for people's experience, and recognising particularly from the kind of ACE theory as to why some of these lives have developed in the way that they have, so that we can provide the help and the recovery that's best placed for that individual.
Yes, and certainly from a college point of view, we hope to be releasing a statement soon on that, hoping to move away from the current mantras into a more public health view of drug-related harms and drug-related deaths, which I think will be much more positive for our patients. yes, we think that general practice should be very much involved in this agenda, but we need specialist services as well. We can't do it alone.
I really welcome that commitment, David. I have to say, because I do think that it's important that my specialty, my profession, plays its part as well, and I look forward to working with you on that.
Yeah. On another topic around health inequalities, Nelson Kennedy's saying, thanks for your insightful introduction to your report. What do you think should be done to ensure the ethnicity gap in health inequalities does not get even wider?
Yeah, and what we've seen is that play out in stark terms over the course of the pandemic as well. And as a consequence of that, there are a number of initiatives which are now underway to better understand, first of all, how those racial inequalities impact on different communities across Scotland. One of the big challenges that we experienced even during the course of the pandemic was actually making sure that we had data which informed that understanding. So there's been some improvements as a consequence of that as well. But I absolutely agree that when you look at some of the communities that we have in Scotland now, whether that be from people who have come from BAME communities or from other cultures such as Gypsy travellers or Romani cultures, then there are inequalities within those communities which we need to fully understand and tackle. I think sensitively as well, recognising that actually there are many difficulties that people experience in some of these communities on a socioeconomic basis that are right at the heart, and sometimes there is mistrust of if you like, I can't get the word just now, but of authority as well, which sometimes impedes people from seeking the help that they need as well. Making sure that we've got the best approaches within those communities to develop trust is going to be a really important part of how we approach that. And using community leaders there is absolutely crucial.
Yeah, thanks. Ed Russell Smith's asking a question which really goes back to how we can develop the profession. How do we tackle negativism? How can exhausted GP educators inspire medical students and junior doctors into primary care and make sure that we keep a sustainable future for the profession? What kind of things do you think we should be looking at?
I mean, it's a wonderful career, general practice. That's the thing. The variety of experience that you get within general practice is for me, I mean, that was part of the attraction for me, certainly, was that variety where you never quite knew what your day was going to kind of be like, how it was going to develop. But I think one of the really important things that perhaps the specialty needs to win back is that sense of longitudinal care and how we achieve that. For me, one of the greatest joys of general practice was providing that care to people as they grew older, as their life stages developed, as their experiences changed, as families grew up, as people came from children into adulthood. I remember one story, David, which was wonderful. And there was, at one point, a little boy was brought into my room, rushed in his mother's arms, blue and with a seizure. And he swallowed his tongue during the seizure. And we quickly stabilised him. And he was fine afterwards. He did a febrile convulsion and in the waiting room. And we managed to kind of take care of him. And I saw that little boy grow up, and then I lost touch with him for 5 years, and I bumped into him a few years later, and he came up and he said hello and told me about what he'd done with his life over recent times. And it was just the most wonderful experience to be able to kind of see exactly how this little lad that came in blue to the room had developed and what he'd done with his life since that point in time. It's very few specialties get that privilege. And I think that one of the things that general practice perhaps needs to remember is that sense of belonging to a community, the presence of the general practice in the community, just the importance that still has to many people, and we can't lose sight of that.
Absolutely. Anna Buckland's asking a question about an area we haven't touched on much, which is mental health. She's saying that there's been a huge impact on mental health and pandemic, and I worry it's going to be a growing and unmanageable workload for GPs and others. What do you think we should be doing to mitigate this?
Yeah, one of the saddest aspects of the last 18 months has seen the effect that this has had on people, both with loneliness, development of anxiety problems, not just low-level problems with mental health, but some severe problems as well as a consequence of it further. That be through sustained levels of stress, or the development of behaviours which have been unhelpful and damaging. Or I agree that I think that this is going to be one of the priorities. So part of that is about making sure that services which are provided to these people get adequate investment in the future. Part of this is about having an open conversation with the public about making sure that they know how to seek help. Part of this is about actually looking at the variety of partners that there now are across communities that can support people who are experiencing distress in some way. And right at the heart of this, for much of the distress that we're seeing, is about how we promote that sense of agency for people. And I think that that's something which we as a profession can contribute to, but I don't think that we can have all the answers. Perhaps the worst thing that could happen as a consequence of all of this is that we reach for a prescription pad and we sign off another 20 milligrams of fluoxetine for people, who's actually the basis of their distress is something which will never be fixed by a tablet that they're taking on a daily basis. But actually, to be able to link to community groups, to links workers, to the supports that we need within the system to be able to provide support them until they've developed the agency to recover themselves, because we can take people so far. Now, that's for that kind of perhaps one echelon of care, but I also think that we need to make sure that the adequate systems are in place for those who are suffering more severe forms of mental illness and distress, is that we've got a responsive system in place in relation to that. And one of the recent announcements that the government has made is about how we actually begin to expand investment into mental health services even further to make sure that they are fit for the future too.
Great. Gregor, just one final question to sum up before we hand back to Karina. Katrina, a quick answer. Daniel Simpson's asking, GP's work's changed quite a lot. Would you still choose to be a GP? And do you think you'll ever find yourself back being a GP?
So the first thing I would say is never say never, but I would have to find a fairly considerate and gentle practice to mentor me back into to make sure I was fit to go back to practice. I would never rule it out, David, I've got to be honest, because I do miss that one-to-one basis. Would I still do general practice every single time? I wouldn't pick any other specialty to start off with. Because even if my career was to develop again in the same lines, I'm glad I never did any other specialty but general practice. And I'll tell you why. General practice is a unique place within the system. We have touch points with our communities, with hospitals, with public health, with social care, right across the system. We understand how that system fits together as generalists. And often we get what I call the helicopter view of how things are working. We're able to see things from a greater level. And I always found that in terms of, I've always had an interest in actually systems and how systems work. And from general practice perspective, I actually think general practitioners have a unique contribution to make to systems thinking and how healthcare systems should operate. And I would encourage anyone who's at any stage of their career, in fact, but particularly at those younger stages of the careers, to have a think about actually how the careers might develop in a way that supports that system change. so that you become system leaders of the future that have that understanding of the different aspects of the system, whilst retaining that understanding from a patient's perspective, that advocacy role that I think general practice has very strongly as well, and to take that into those conversations as you know, the next generation of people try to improve the system as well.
That's a great summing up, Gregor. Thank you. Katharina, over to you.
Well, I guess it just remains for me to say thank you so much, Gregor, for coming along tonight and sharing with us, sharing your musical taste. Thank you for all of that. Thank you for your openness and your vulnerability, and sharing some really personal insights about your career and your life in the Desert Island Discs section. And also thank you for sharing about your report. And it's great to hear about the passion that you have for general practice, and the work that you're hoping to do with the college going forward, and just the issues that you're addressing and you have continued to address as a result of your report. And you will continue to do that in the future. So really appreciate your time. And I just want to say a big thank you to Chris and David for chairing and doing the Desert Island Discs format, and also for picking up on lots of questions. And thank you so much to Kirsty for doing all the technical aspects, and for all of you for coming. Thank you for giving up your evening or part of your evening to be here. We really appreciate you coming. So it remains for me to say thanks once again, and hope to see you at our next event. Take care.
Thank you so much.
Thank you.